Hi, good evening, friends. Pradeep Pendiala. Today I am going to talk about pregnancy and anesthetic implication. This is a very interesting topic. Beyond 20 weeks of gestation, there is high chances of regurgitation during pregnancy. I'm sure you would agree. Enlarged uterus would definitely displace the stomach and pylorus cephalad, and this reposition can cause intra-abdominal pressure over the esophagus. And naturally, there would be changes in the gastroesophageal sphincter. The tone of the gastroesophageal sphincter is reduced by hormonal changes like increased progesterone and estrogen during pregnancy. So there is chances of aspiration is very high. Gastric pressure increase because of the gravid uterus also. This has to be remembered when you're giving anesthesia to a pregnant lady. So this is how the pregnancy and the anesthetic implications should be viewed upon. And regardless of what amount of time has elapsed, always consider, if a lady is coming for cesarean, always consider her to be a full stomach lady, because the chances of aspiration, regurgitation is very, very high. If you are giving general anesthesia, rapid sequence induction with cricoid pressure is strongly indicated with cuffed endotracheal tube. That's a must. Preferably go for regional anesthesia. If not, if you are giving general anesthesia, this must be the thing. MAC is what? Minimum alveolar concentration. Is normally reduced during the pregnancy. However, it's not been proven fully, but there is definitely indication that MAC decreases, especially in the first trimester of pregnancy, even up to 40%. That is it. Human studies have been shown to be around 30%. During pregnancy, I'm sure you would agree, the epidural space is decreased because of the increased pressure. So, epidural and intrathecal spaces both have changes because of the increased gestational pressure onto the sac. So, the decreased volume of epidural space have its own implications, and there will be engorgement of epidural veins and increased intra-abdominal pressure, resulting progressive enlargement of the uterus. So that is it. So you have to keep these things in mind whenever you are giving anesthesia for pregnant lady. Renal blood flow and GFR are normally increased. So even to the extent of 50%. During pregnancy. This results in normally the blood urea nitrogen and creatinine to be changed. 50% is decreased during the pregnancy. Renal blood flow and abdominal filtration return to normal immediately after delivery or after cesarean. During 3 to 4 months postpartum, everything comes back to normal and preconception state. So, hepatic blood flow does not change significantly. However, plasma proteins concentrations are reduced, so keep in mind the decreased albumin level can create increased blood levels of high protein bound drugs. I'm sure you know plasma cholinesterase, or also known as pseudocholinesterase level, decreases during pregnancy to the extent of even 30%. So naturally it can have effects on action of succinylcholine or scoline. When you are giving anesthesia to a pregnant lady, always remember 4H. Hypertension, hypoxemia, hypovolemia and hypothermia. This you have to avoid. As far as possible, keep in mind there should not be premature uterine contractility. contraction or activity. And must remember, use of any drug which might be contraindicated during pregnancy for the fetal growth or on the fetus teratogenic effect. There should be always optimal oxygenation to the mother during any time of giving anesthesia, whether it's regional or in general anesthesia. Interestingly, all the three trimesters have different reactions with anesthesia, first, second, and third trimester. Labor analgesia has its own effects, so you have to know what is what and how these things are affecting, whether it is obstetrical or non-obstetrical emergency or surgery. Effort should be directed at minimal radiological exposure as far as possible. Thorough counseling of parturian and her relatives is a must, and besides that, there should be a lot of discussion and understanding between the gynecologists, obstetricians, and the anesthesiologists, as well as the pediatrician, I would say. Pre-medication should include S2 blockers like ranitidine and add sodium citrate to minimize the risk of aspiration. As I had just mentioned, lower esophageal sphincter tone is reduced during progesterone extra circulation during pregnancy. So keep in mind, as far as possible, there have been instances of itocaval compression also, obviously because of the gravid uterus. And after 20 weeks of pregnancy, gestation will be a lot of pressure. And that can cause hypertension and decrease cardiac output because of the decreased venous return. So always make sure you don't give heavy doses of non-steroidal anti-inflammatory drugs also. This can cause premature closure of ductus arteriosus, so that could cause big problem. As I just mentioned, gravid uterus while compressing the inferior vena cava also causes dilatation of the epidural plexus. So that would have effect on the local anesthetics which you are using, and it can cause inadvertent intravascular injection. So you have to plan it accordingly. The physiological parameters would be different in first trimester, second trimester, and third trimester. These physiological changes affect nearly all major organ systems, including the cardiovascular, pulmonary, renal, hepatic, nervous system, and there could be metabolic changes which could be different during pregnancy. The increasing requirement of both maternal and fetal tissues put extra demand of extra oxygen consumption. So make sure that there is no hypoxemia to the mother during giving anesthesia. At the same time, hyperventilation during pregnancy can cause carbon dioxide washout. That could result hypocarbia. And this has got implication because there has been decrease on MAC also, and there will be fast inhalation induction because of decreased functional residual capacity. For obvious reasons, there could be rapid induction and there could be greater risk of hypoxemia. So be careful with it. During general anesthesia, there could be decreased carbon dioxide because of the reasons I just mentioned, and the decreased carbon dioxide can result vasoconstriction, leading to decreased maternal cardiac output and compromise even the uterine blood flow. So you have to titrate the anesthetic drugs accordingly for obvious reasons. The significant cardiovascular changes include increased blood plasma volume, RBC volume. Although plasma volume increases, but RBC volume also increases, there will be physiological anemia because increased plasma volume compared to RBC. There will be increased cardiac output during pregnancy. There could be increased heart rate, and there could be few benign changes Like there could be benign arrhythmia, which is not warrant you or alarm you, but there could be few benign arrhythmias such as STT and Q wave changes, and left axis deviation also are seen in few pregnant ladies. However, we have to be very careful if there is overt cardiac pathology such as presence of systolic murmur to the extent of grade 3 or diastolic murmur or severe arrhythmias, you must take consultation of the cardiologist. Otherwise, don't worry. As I mentioned, there could be difficulty in intubation because of laryngeal edema, engorged and enlarged breasts. Breasts would come into the way of intubation, and anterior-posterior diameter of the chest also increases, and soft tissues of the neck. And laryngeal area, there could be edema. So, the intubation or instrumentation is will be difficult, and preferably avoid nasal intubation because of high risk of bleeding, because the vascularities of the mucous membrane of the nose will be very, very high. So don't try nasal intubation as far as possible. And I have just mentioned plasma cholinesterase levels are decreased more than even 30%. So when you are giving choline, be cautious. There could be prolonged effect of choline. Neuromuscular monitoring could be of help, and always remember about the decreased plasma cholinesterase level. Fetal monitoring should be done as far as possible with Doppler ultrasound. And this is very essential. Risk to the fetus are high, and regional anesthesia should be the first choice. Repeatedly, I would say, regional anesthesia is the first choice, always. And moreover, the risk of teratogenicity of the fetus during first trimester should be always remembered, and the number of drugs which you give in general anesthesia is very, very high. Second trimester has its own problems, and the most common non-obstetrical surgical emergency could be pregnancy with appendicitis, cholecystitis, intestinal obstruction. Less common surgical conditions could be torsion of ovarian cysts and masses, like it could be intercholelithiasis, adrenal tumor, hernias, complication of inflammatory bowel disease. All these things can happen, and aortocaval compression should be always prevented by left lateral position or putting a wedge under the right buttock. That would shift the pressure to the left, and the pressure on the vena cava is reduced. Vena caval compression also increases distension of the epidural venous plexus, which I had mentioned, and which would cause inadvertent intravascular injection while giving regional block. So you should always remember that. And third trimester has its own problems. Analgesics, sedatives, and anesthetics must be used with caution for cesarean delivery, as they can have profound effect on neonatal health and Apgar scores. Should always remember that. Labor analgesia has been improving, and things have become very, very advanced in labor analgesia. Parenteral opioids such as pethidine, fentanyl, tramadol, butorphanol, or remifentanil have been used successfully for labor analgesia. Then, Entanox has been used earlier, but it's not all that effective compared to labor analgesia. Labor analgesia is any day much superior, and it could be converted into proper anesthesia of regional block for if it is converted to cesarean also. So surgery also can be done with the same labor analgesic catheter, epidural catheter. So that is the advantages. Some people also have shown doubt while giving labor analgesia chances of surgical intervention like cesarean's chances are increasing, but however, it's not been proven as yet. And incidentally, adjuvants such as opioids, alpha-2 agonists such as clonidine, dexmedetomidine, or neostigmine have been extremely useful in labor analgesia. And its presence can decrease the actual dose which is supposed to be given of the local anesthesia. So that's a huge advantage. You just can't forget that. And I would say when you are giving anesthesia, you should always remember, preferably regional anesthesia. GA should be considered only on very, very rare instances like when there are coagulation abnormalities or patient's refusal for spinal or regional epidural anesthesia, or where there is contraindications of regional anesthesia like local infection or deformity of the spine or any neurological diseases. Such rare occasions you have to go for general anesthesia. Otherwise, always go for spinal or epidural as far as possible. Spinal is very effective, very, very useful as far as I know, and my experience is spinal is supreme, absolutely safe and absolutely good. And general anesthesia, in case there is a difficulty of intubation, your supraglottic devices such as ProSeal laryngeal mask airway and intubating laryngeal mask airway have totally revolutionized general anesthesia. Like as I said, because of the laryngeal edema and engorged breasts and difficulty of intubation, always go for a one size smaller endotracheal tube when you are trying to intubate. And if you have failed to intubate, these kind like laryngeal mask are very useful. ProSeal laryngeal mask or intubating laryngeal mask. Totally revolutionized. Regional anesthesia is always preferred because you can avoid airway manipulation. I would always advise regional anesthesia. I don't mind saying 100 times. And incidentally, postpartum period is exactly the period which resembles the initial part of the first trimester. All the changes are very, very similar to what has happened in the first trimester, first 6 weeks of pregnancy. Very simple. It's almost like the same thing. New physiological parameters normally get restored back to non-pregnant level by around 6 weeks or so during postpartum period. Then we must know that Food and Drug Administration, FDA, has advised certain drugs which have to be very carefully given. Luckily, fortunately, most of the anesthetic drugs which we use do not harm much mother or the fetus. But however, you must know which category and what. Category A is controlled human studies have demonstrated no fetal, that's absolutely safe, category A drug. B are the ones where animal studies indicate no fetal risk, but no human studies have taken place. C, no adequate human or animal studies or adverse fetal effects in animal studies, but no available human data. So be careful. Category D, evidence of fetal risk, but benefit outweighs risk. Always see the balance, which is what? Evidence of fetal risk, but benefits outweighs risk. So go for it. Evidence of fetal risk, but risk outweighs any benefit. That is category X. So don't go for it. Don't ever venture into it. Now, I'll tell you some few drugs which are very, very interesting. Like this drug, which we always use, bupivacaine. It comes into the category C. Lignocaine comes into the category B. So this is how we have to know which drug and what. And what we use, propofol. Propofol in category B, morphine in category B, and remifentanil and sufentanil in category C, and butofenol, which we use very often, is category C. Succinylcholine is category C. Rocuronium is category C. Thiopentone, which you often use, in category C. Lignocaine and bupivacaine, I have already mentioned lignocaine B and bupivacaine C. So this is that. Thanks for patient listening. I'm sure it was very, very informative talk. Kindly pay attention to what I have said in this video. Thanks for patient listening. Until next time, bye-bye. This is Colonel Pradeep Pendyala, Professor of Anesthesiology at Asram Medical College, Eluru City of Andhra Pradesh, India. Bye-bye.